Welcome to the lower respiratory tract infections, where we list the common microbial agents, describe their microbiological properties, pathogenesis, laboratory diagnosis, along with treatment and prevention. LRT infections affect the trachea and lungs. There are 6 main types you need to know. Bronchitis is infection of the large airways or bronchi. Bronchiolitis involves infection of the small airways or bronchioles, most common in infants. Croup is infection of the trachea, particularly in children. Influenza causes widespread infection affecting both upper and lower respiratory tracts. Pneumonia is infection of the alveoli and surrounding lung tissue, the most serious LRTI. Finally, lung abscess represents localized destruction of lung parenchyma, usually as a complication of pneumonia. Pneumonia can be classified based on the anatomical pattern of lung involvement. Understanding these patterns helps interpret chest X-rays and predict causative organisms. Lobar pneumonia involves a complete lobe of the lung, polymorphonuclear exudate clots in alveoli, making them solid. Infection spreads to adjacent alveoli until stopped by anatomical barriers. This creates complete consolidation of one lobe, typically caused by Streptococcus pneumoniae. Bronchopneumonia shows patchy consolidation spreading throughout the lung, originating from infected small airways. Multiple patches affect both lungs, common with Staphylococcus aureus or gram-negative bacteria. Interstitial pneumonia involves invasion of the tissue between alveoli. This pattern is characteristic of viral infections and atypical bacteria, like Mycoplasma. Lung abscess or necrotizing pneumonia causes cavitation and destruction of lung tissue, appearing as holes on chest X-ray. Pneumonia classification helps predict likely causative organisms and guide empirical treatment. Pneumonia affects alveoli or alveolar walls, and causes depend on clinical and epidemiological factors. Classification by acquisition method. Inhalation pneumonia occurs from breathing infectious particles. Aspiration pneumonia results from inhaling stomach contents or oropharyngeal secretions. Classification by location. Community-acquired pneumonia occurs outside hospitals. Healthcare-associated pneumonia develops in hospitalized patients or those in healthcare facilities. Classification by presentation. Typical pneumonia presents with sudden fever, productive cough, and lobar consolidation. Atypical pneumonia has gradual onset, dry cough, and patchy infiltrates. Other factors affecting causative organisms include patient age and immune status. Either immunocompetent or immunocompromised patients have different pathogens. Inhalation of airborne infectious particles is the primary route. Small particles remain suspended in air after coughing or sneezing and can be inhaled directly into alveoli. Aspiration pneumonia involves inhaling resident nasopharyngeal flora or large airborne particles after deposition in the nasopharynx. This is endogenous infection from the patient's own bacteria. Hematogenous spread occurs when organisms from another infection site travel through blood to lungs, causing bilateral pneumonia. Direct extension happens from adjacent infection. Entamoeba histolytica can spread from liver abscess. Influenza and RSV spread from upper to lower respiratory tract via epithelial infection. Exogenous penetration occurs through trauma like road accidents or surgery, directly contaminating lungs. Specific risk factors predispose patients to particular organisms in community-acquired pneumonia. Diabetics are at risk for Burkholderia pseudomalaei, a bacillus with characteristic safety pin appearance, causing melioidosis. Alcoholics commonly develop pneumonia from Streptococcus pneumonia, appearing as capsulated diplococci, or Klebsiella pneumonia, capsulated bacilli causing severe necrotizing pneumonia. Patients with underlying respiratory disease like COPD are susceptible to Streptococcus pneumonia and Haemophilus influenzae. Cystic fibrosis patients frequently get Pseudomonas aeruginosa infections. Prior viral infections predispose to secondary bacterial pneumonia, particularly Staphylococcus aureus or Streptococcus pneumonia. Occupational exposure affects farmers, veterinarians, and abattoir workers who are at risk for Coxiella burnettii and Brucella species. Healthcare-associated pneumonia, particularly ventilator-associated pneumonia, presents unique challenges due to multi-drug-resistant organisms. Common causative organisms include Pseudomonas aeruginosa, an opportunistic gram-negative rod thriving in moist environments, including ventilator circuits. Klebsiella pneumoniae, another gram-negative rod, often produces extended-spectrum beta-lactamases conferring antibiotic resistance. Escherichia coli can cause pneumonia in hospitalized patients. Acinetobacter baumannii is increasingly problematic due to extensive drug resistance. The importance of healthcare-associated pneumonia lies in difficulty treating these infections due to multi-drug resistance. These organisms often resist multiple antibiotic classes, requiring combination therapy or last resort antibiotics like colistin. Prevention through proper infection control, including hand hygiene, ventilator care bundles, and appropriate antibiotic stewardship, is critical for reducing these serious infections. This table summarizes causative organisms for 3 important lower respiratory infections. Croup primarily affects young children. Bacteria rarely cause croup. Viruses predominate, particularly parainfluenza viruses, influenza viruses, and adenoviruses. Bronchitis can have bacterial or viral causes. Bacterial agents include Bordetella pertussis causing whooping cough, Haemophilus influenza, Mycoplasma pneumonia, and Chlamydia pneumonia. Viral causes include parainfluenza, influenza, RSV, adenoviruses, and measles. Overall, viruses predominate in bronchitis. Bronchiolitis primarily affects infants under 2 years. Mycoplasma pneumonia can cause bacterial bronchiolitis. Respiratory syncytial virus is the predominant cause, accounting for 75% of cases. Other viruses include parainfluenza, influenza, and adenoviruses. RSV is clearly the most important pathogen in bronchiolitis. This table categorizes pneumonia by acquisition location and lists common causative organisms. Community-acquired pneumonia organisms include Streptococcus pneumoniae, the most common cause overall. Haemophilus influenzae causes pneumonia particularly in COPD patients. Atypical organisms include Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella pneumophila. Viruses like influenza and RSV cause viral pneumonia. Healthcare-associated pneumonia features different organisms. Pseudomonas aeruginosa is common in ventilated patients. Klebsiella pneumoniae often produces beta-lactamyces. Staphylococcus aureus, including MRSA, causes severe necrotizing pneumonia. Escherichia coli and Acinetobacter species are increasingly important. Aspiration pneumonia involves anaerobes from oral flora, like Bacteroides, Prevotella, and Fusobacterium species, plus Streptococcus species. This slide reiterates the importance of healthcare-associated pneumonia, particularly ventilator-associated pneumonia, which we covered earlier. The key causative organisms are Pseudomonas aeruginosa, Klebsiella pneumoniae, Escherichia coli, and Acinetobacter baumannii. These gram-negative organisms thrive in hospital environments and colonize respiratory equipment. The critical importance is their multi-drug resistance patterns. These organisms often possess multiple resistance mechanisms, including beta-lactamases, efflux pumps, and altered drug targets. This makes treatment extremely challenging, requiring combination antibiotics and longer treatment durations. Prevention strategies are paramount, including proper hand hygiene, sterile technique during ventilator management, elevating the head of the bed, and antibiotic stewardship to prevent resistance development. The source of respiratory infections is infected persons whose respiratory secretions contain infectious agents. This includes individuals with active disease and asymptomatic carriers who harbor organisms in their nasopharynx. Mode of transmission occurs person to person through 2 main routes. Contact transmission happens through direct touch, such as shaking hands with infected persons, or indirect contact by touching contaminated surfaces, then touching your face. Airborne transmission occurs through coughing and sneezing, which expel respiratory droplets containing infectious agents. Large droplets settle quickly on nearby surfaces, while small aerosolized particles remain suspended in air and can travel farther distances. This understanding emphasizes why hand hygiene, respiratory etiquette covering coughs, and isolation precautions are critical prevention measures in healthcare settings and communities. This is a classic presentation of lobar pneumonia. A 67-year-old man presents to emergency with abrupt onset of shaking chills, high fever, and right-sided chest pain that began the previous evening. His wife reports 24-hour history of shortness of breath and productive cough with rust-colored sputum. The rust-colored sputum is characteristic of pneumococcal pneumonia, resulting from red blood cells in alveolar exudate. Important risk factors include diabetes and heavy smoking, 2 packs daily for 20 years. Both impair immune function and lung defense mechanisms. Chest X-ray shows consolidation of right upper lobe, indicating lobar pneumonia pattern. This presentation is classic for Streptococcus pneumonia, the most common cause of community-acquired pneumonia. The combination of sudden onset, high fever, pleuritic chest pain, rust-colored sputum, and lobar consolidation strongly suggests pneumococcal pneumonia requiring urgent antibiotic treatment. The polysaccharide capsule is the major virulence factor, interfering with phagocytosis by preventing opsonization. Encapsulated strains are highly virulent. Choline-binding protein A acts as an adhesant, helping pneumococcus attach to nasopharyngeal epithelial cells, enabling colonization. Autolysin aids in releasing intracellular virulence factors when bacterial cells lyse. Pneumolysin is a cytotoxin-binding cholesterol in host cell membranes, causing lysis of phagocytes and ciliated epithelial cells, while stimulating pro-inflammatory cytokine production. IgA protease breaks down secretory IgA, preventing antibody attachment and facilitating mucosal colonization. Teichoic acid activates complement, contributing to inflammation. Hydrogen peroxide produces reactive oxygen intermediates, damaging host tissues. These combined factors make pneumococcus a formidable pathogen, causing significant morbidity and mortality. The source is healthy individuals colonized with pneumococcus in their nasopharynx. About 5 to 10% of adults and 20 to 40% of children carry pneumococcus asymptomatically. Endogenous transmission involves spread from the patient's own nasopharynx to lungs when resistance is impaired. Susceptibility results from general debilitation like malnutrition or alcoholism, respiratory damage following viral infections, or depressed immune systems. Patients with sickle cell disease or those who've had splenectomy are particularly at risk because the spleen plays a crucial role in clearing encapsulated bacteria. Exogenous transmission occurs through respiratory droplets from carriers' noses and mouths during talking, coughing, or sneezing. Colonization. S. pneumonia colonizes the nasopharynx using adhesins, example pneumococcal surface proteins, and IgA protease to evade mucosal immunity, often asymptomatically, especially in children or following viral URI. Aspiration and invasion. Impaired mucociliary clearance, as in due to viral infection, smoking, or alcohol, allows aspiration of a large inoculum into the lower airways, bypassing upper airway defenses. Evasion of innate immunity. The polysaccharide capsule inhibits opsonization and phagocytosis by alveolar macrophages, enabling bacterial survival and replication in the alveolar space. Local inflammation and consolidation. Bacterial multiplication triggers release of inflammatory mediators like TNF-alpha and interleukins, increasing capillary permeability. Right-pointing arrow serum. Neutrophils, PMNs, red blood cells, and fibrin flood the alveoli. Right-pointing arrow alveolar macrophages are recruited, and antigen-presenting cells activate B and T cells in draining mediastinal lymph nodes. Right-pointing arrow infection spreads contiguously to lobar consolidation stage, is visible on CXR as homogeneous opacity with air bronchograms. Systemic manifestations. Cytokine spillover causes fever, rigors, myalgia, and tachycardia, classic signs of acute infection. Potential complications. If unchecked. Bacteremia. Right-pointing arrow metastatic infection spreads to meninges, endocardium. Sepsis/septic shock from cytokine storm. Respiratory failure due to ventilation-perfusion mismatch and reduced compliance. Haemophilus influenzae is an important cause of pneumonia, particularly in patients with chronic lung disease. Let's understand its microbiological characteristics. Haemophili are small, pleomorphic, non-motile gram-negative rods or coccobacilli. Pleomorphic means they vary in shape. The polysaccharide capsule is the major virulence factor. 6 capsular types exist, designated A through F, with type B historically most pathogenic. They're aerobic and facultatively anaerobic. Adding 5 to 10% carbon dioxide enhances growth. Hence they are known as capnophils. Haemophilus species require specific growth factors, X factor hemin and V factor NAD. Different species require one or both factors, distinguishing it from other Haemophilus species. This requirement explains why it grows on chocolate agar, where heating releases both factors from red blood cells, but not on blood agar where V factor remains intracellular. H. influenzae is a normal upper respiratory tract flora component in humans, also colonizing the conjunctiva. Humans are the only natural hosts, with colonization beginning shortly after birth. IgA protease produced by the organism degrades secretory IgA, facilitating upper respiratory tract mucosal colonization. This allows bacteria to persist in the nasopharynx, despite immune defenses. Bronchopneumonia results from contiguous spread from the colonization site in the respiratory tract. Unlike pneumococcus causing lobar pneumonia, H. influenzae typically causes patchy bronchopneumonia, particularly in patients with chronic obstructive pulmonary disease or following viral infections that damage respiratory epithelium. The organism's ability to persist in the respiratory tract and cause disease when host defenses are compromised makes it an important pathogen in specific patient populations, particularly those with underlying lung disease. In conclusion, LRT infections represent serious diseases requiring prompt recognition and treatment. Understanding the types of pneumonia, causative organisms based on epidemiological factors, virulence mechanisms, and pathogenesis provides the foundation for appropriate clinical management. Streptococcus pneumoniae and Haemophilus influenzae remain major bacterial causes, each with distinct characteristics and clinical presentations.